This is chapter 19. It's problems in achieving pain control. First thing I want to do is go over the contents in a cartridge. You're going to see that there is local anesthetic, whether it's lidocaine, bupivacaine, plain. It's what goes in there. Then if you go down to the two at the bottom, it's going to have sodium chloride and sterile water. It could also say distilled water. It's the same thing as the diluent, and that is what is in a plain anesthetic, like bupivacaine plain. So if it's going to have a vasoconstrictor with it, you'll add that, and if there's a vasoconstrictor, there has to be a preservative for the vasoconstrictor, and that is sodium metabisulfite. So you're going to see bisulfite, or you're going to see the word metabisulfite. It's one and the same. You would choose either one if it was in a question on a test. I included methylparaben. It's been banned for decades, but they used to use methylparaben in there as a preservative and a bacteriostatic component, but they noticed that certain amount of people had allergies to PABA, and so the paraben part of it, they needed something else to put with it as a preservative or an antioxidant, and so they chose sodium metabisulfite or bisulfite. So the reason I put this on here is to bring it to your attention, because I've seen questions to where it's multiple choice, and they'll say choose the all of the above or all of the below have our contents in a cartridge, and they'll have methylparaben in there, and so sometimes people get confused. They remember hearing PABA and paraben on something, and so they choose that, and you would not choose that. It's been banned. It is not in a cartridge. On the maxillary teeth, if you have problems with anesthetic, first of all, you need to know that the infiltration is still the preferred injection when you're only anesthetizing one or two teeth. And that is due to the fact that it's got a very thin cortical plate bone. And so you're always going to have more success on the maxillary. Infiltrations are still the most used injection. And mostly I think that's due to the dentists, because they a lot of times are filling one tooth or two teeth, and maybe they'll do an infiltration with a stronger anesthetic to be able to get that one tooth. So the infiltration is the most used. The second most used would be the IA in all of dentistry. So failure of anesthesia in this area is due to some people that have a thicker maxillary cortical bone. And the other reason that you might fail on this is that you need to inject higher or at the root apex, especially on the canines and the centrals. Using an intranasal mist is another option. We don't really have any of that as a hygienist, but dentists can use this intranasal mist of 3% tetracaine, and it's been proven to provide profound pulpal anesthesia of the maxillary centrals, canines, and premolars. Doesn't do so great on the molars. This was found out by ENTs, ear, nose, and throat doctors, and they noticed that when they would use this intranasal mist for their procedures, the patients would complain and say that their maxillary teeth were numb. And so that led to a whole research in maybe we could just give an intranasal mist of some type, and then you wouldn't have to give your patient an injection. But there are other issues with the mists of if you use it a lot, certain ones that are strong can do harm to the nasal cavity. So they're still in the throes of figuring all that out. You can use cold refrigerant. They have one that's called Endo Ice, and they will spray some of that on a cotton roll and put it up to the tooth. And if the patient can feel it, then they know that they're not numb yet. And of course, they can use a pulp tester of some type. On your maxillary molars, even though it's not as successful, it is still the most used injection infiltrations on the maxillary molars. So failure could be because of thickness of the bone over the molars or the anatomy of the first or second molars. Sometimes the palatal root on those maxillary molars flare out toward the midline of the palate, so it doesn't receive all of the anesthetic like the buccal roots would, so that could be an issue. So solutions to this would be that you could perform the PSA injection even if there's only one molar that you need. You could always use a buffered local anesthetic solution, and that's mainly for the dentist because, like I said, most hygienists don't have access to that, and if you do have access to it, it takes a minute to do, and if you're on a 45-minute or 50-minute appointment, then it's, tick-tock, tick-tock. So you can perform the maxillary infiltration with a buffered 4% articaine, or you actually can do the same thing without the buffered part of it, because 4% articaine on that infiltration is very strong, and it usually always has success. And profound anesthesia at that. So you could perform a supplemental injection such as the periodontal ligament, interosseous, interseptal. They're very rarely needed, especially for hygienists. We're usually not doing just one tooth here and there. We do mostly blocks, but we may have to supplement with these infiltrations once in a while. On the mandibular teeth, the IA has a really high rate of failure, as we've talked about. So a simple infiltration, like we do in the maxillary arch, is kind of iffy in the mandibular arch due to that thick cortical bone. So what you can do is you can give the Gow Gates or the Vazirani Akinosi, which I hope no one will ever have to give, that Vazirani Akinosi. But you could also give just a really slow injection, which is one cartridge over 60 seconds or 1 full minute. And you could use a buffered solution with 4% articaine for an infiltration on the mandible. You can use, once again, without the buffered solution, you can use a 4% articaine with epi for an infiltration on all 3 back molars if you want on infiltrations. You just cannot ever use a 4% articaine when you go 16 millimeters, far away up when you're doing the IA. You can't use it at that point. So, but for infiltrations, you could use them on those back teeth for sure. So you could also give supplemental injections, and once again, the periodontal ligament, interosseous, or interseptal, which, like I said, we'll go over in another chapter. And that will end this chapter.